this educative series. On behalf of Fortis Mulund, I would like to welcome all our eminent doctors who are adding the spark to the event. I would like to request to give a big round of applause for all you. Lighted lamp is the symbol of auspiciousness, and it is our Indian tradition to light the lamp before starting the program. So, before we proceed with our today's event, let us begin with the lamp lighting. May I call upon Dr. Naraini, Dr. M.B. Agrawal, Ms. V.G. Venkatesh, and Dr. Subhaprakash Sanyal to please come up on the stage and light up the lamp.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you so much, everyone.
दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म.
Today's CME will dwell on hematology, and we have Dr. S. Naraini, our business head, Fortis Hospitals, Maharashtra, who is going to introduce us about the topic and elaborate about our new institute and way forward about Fortis Institute of Blood Disorders program. Dr. S. Naraini is associated with Fortis Group since 2 decades. Her sheer determination, passion, and zeal has paved the way for modern healthcare practice with quality and patient centricity. Her continuous pursuit for excellence has put Fortis Muller on the map as one of the top hospitals in Mumbai. Furthermore, she is proud winner of the Women Leadership Award, and she was chosen as one among the 100 most impactful healthcare leaders. Dr. Naraini has been pivotal in spearheading such scientific programs at the hospital, and she believes in the fact there can be no end to the learning. I warmly welcome Dr. Naraini ma'am to present her address.
Thank you, Gayatri. A very good morning to all of you all and a very warm welcome. It gives me special pleasure to welcome you all, most especially Dr. M.B. Agarwal, Dr. Mrs. Agarwal, Ms. Viju Venkatesh, and all our doctors and others who are present over here. It is actually a very, very good feeling after 2 years of being locked onto the screen and having online discussions to actually move into a physical room and have these kind of interactions all over again. And I'm sure this is going to make this very, very special. What we're doing today, launching of our institute, Fortis Institute of Blood Diseases, is actually special for us. It's a very special occasion, and it's special for multiple reasons. I personally have a very special feeling about this, and I'll tell you why. While I'm standing here and get introduced as the head of Fortis, I am actually by training a pathologist. And in the lab, there are many things which excite you, but the one thing which always excited me the most was understanding blood, understanding CBC, understanding coagulation, because I felt these were the simple things which made so much of a difference to what can happen to a patient and how a patient is treated. More importantly, all that I learned about coagulation and all that I learned about the various aspects of CBC, I learned from Dr. Agarwal. I used to come rushing from AFMC in Pune, where I was pursuing post graduation, to attend his clinical update sessions, the famed ones which used to happen in Bombay Hospital, the 2-day sessions I used to come for. And back then, I never knew that one day we would have a day like this where we have him inaugurating Institute of Blood Diseases in a hospital where I also work. So it's really wonderful for me personally to have this, and wonderful for Fortis to have this session. Secondly, over a period of time, healthcare has grown so much. The specialities have grown, technologies have grown, what we can do, what we can treat, what we can diagnose has really exploded. Every organ has become a specialty and with multiple subspecialties. All the solid organs seem to have a department. I don't know, I don't see too many places where there is this liquid spe- organ which has a department of its own. And I see a look of smile on Dr. Agarwal's face, and we thought it's high time we developed a department for the liquid organ, that is blood, which is all pervasive and accounts for so much more than some of the solid organs do. And it is our delight that we have the right clinicians, we have the right team, and we are able to provide the right infrastructure to get this going. And I think we're going to make a lot of difference to the community and people, because the blood disorders far exceed the other disorders of other organs. I'm sure all of you all will agree with me, and both in the area of the benign as well as in the malignant. Finally, there's one other thing which I would like to mention over here. Fortis Hospital Mulund has been now around for 2 decades. It came into existence in 2002 more as a hospital which was a need of the community. And rightly so, at that time, we started off actually as a cardiac hospital. Today, 20 years of existence, 2 decades of being there in Mulund, we've changed what we were. We've gone on from step to step, and we've now become a multi-speciality tertiary care hospital dealing with every specialty, every modality of treatment which we can offer. And adding this department today is just adding another feather in our caps. But what excites me about this hospital is what I want to share with you. Fortis Hospital, as all of you all know, is a corporate hospital. And it doesn't scare me to say in front of this audience that typically the word corporate hospital is considered a bit of a bad word. People often think that a corporate hospital is a place where we are hungry for patients, we are hungry for numbers, and hungry for earning. I want to tell you all, and I hope most of you all have already experienced this, and most of you all have heard about this, and you believe it, that Fortis Hospital is a corporate hospital. It is hungry for more patients. It is hungry for lots of patients to be treated by us, but not in the way people perceive a corporate hospital to be. We are a hospital where, right from the beginning, the ethos has been that we should be patient centric. What I mean by patient centric is give the patient the right outcome every time he comes. Treat the patient only for that for which he needs to be treated. And a hospital would be successful if we had the right set of clinicians. So we have, in all these 20 years, added to our family, our Fortis family, which we call it, which are all the talented clinicians who come with a vision, who come with a thought process, who come with what they want to do for the community. And as administrators, what we do is actually support them. We try to support them with the infrastructure, we try to support them with the technology, and we try to support them with the processes. And if we are able to keep our patients in a state of happiness, And if we are able to keep our clinicians satisfied in terms of the support we give them, we think we have done a good job of what we are supposed to do. I believe this is a motto which we've been practicing reasonably successfully because we have brought to the community several firsts. We started the hospital in 2002, and we were the first to start a hospital which had a dedicated pediatric cardiac center, pediatric cardiac surgeries. Subsequently, we went on to the area of oncology, comprehensive oncology, with going right up to support the clinical support systems. We went on to developing transplants. We gave the city of Mumbai and the state of Maharashtra heart transplant as a very viable treatment option for patients suffering from end stage cardiac disease. And similarly, we've done excellent critical care. We rose up to the occasion during COVID, and we were able to serve perhaps the largest number of patients who needed both critical as well as non critical care. And now we are expanding on what we do in the area of blood dyscrasias and giving it a formal touch by actually launching the Fortis Institute of Blood Diseases. So Fortis is a hospital which has been around for 20 years, serving the community. We are very proud of our clinicians. Many of them started out young with us, and they become names to reckon with today. And we are happy with the advancements in terms of technology and others which we are able to make, so that we are there for the community to come and reach out to us. And as I speak, I would say with 20 years, we finished one chapter, and we are now getting ready. Perhaps this event is one of the first in our new chapter which starts, which I call the Fortis Mulund version 2, which will incorporate all that is changing around us in healthcare, which includes the whole digital technology, it includes the distance connect, it includes looking at newer specialties, it includes having technology, but using technology only where it is needed so that you can give patients affordable care, which is still the best that they can get. So, in all of this, I'm sure you now understand why it becomes so much more special this day for us to have this event and for us to have all of you all and kind of set in motion the phase two of version two of Fortis Mulund, which is going to be hopefully with the support from all of us, with the support of all our clinicians, another very big success story in terms of the wonderful clinical patient centric care which we are able to provide. Thank you all once again for being here, and I wish you all a wonderful clinical session ahead. Thank you.
Thank you, ma'am, for the wonderful insight for the way forward about our hospital. The field of medicine has always progressed on the learnings gleaned from real life situations. One of the most effective educational tools is in the presentation of case studies and the fruitful discussions that emerge from them. May I welcome Dr. Hamza Dalal, our hematologist at Fortis Mulund. Dr. Hamza is a consultant in the Fortis Institute of Blood Disorders. He was awarded the President's Gold Medal in the final examination of DNB Haematology at 21st Convocation of the National Board of Examination. He also has a postgraduate diploma in the field of geriatrics and has keen interest in the field of geriatric hematology. Dr. Hamza and his team will lead the presentation of case studies and the forthcoming discussion. I request Dr. Hamza to take the stage.
Thank you, Gayatri, for the kind words. So, a very good morning to all the dignitaries present today. So, just a few words at the beginning. So, as a medical student, it was always very clear to me that I would become a practicing physician one day. But knowledge about super specialty branches during MBBS is limited to the occasional lectures taken by honorary professors in our third year of MBBS. So, one such lecture was very much sought after by all the MBBS students in science, and that was conducted on the hematology topics by Dr. M.B. Agarwal, sir. So the enthusiasm which Sir used to teach and discuss the basics and advances in hematology has not diminished by even 1% over the past so many years, probably more than 15 years. In fact, it has only increased. So Sir has been conducting regular weekend CMEs in the past 2 years during the entire COVID, which has allowed us to be abreast with all the recent advances which have been taking place in the West. He remains an inspiration and a perennial source of knowledge to all those who practice and who aspire to practice hematology throughout the country. Thank you, sir. For the practice of hematology, one requires not only an in depth knowledge of clinical medicine, but also an astute skill of laboratory diagnosis. So, one can say that a hematologist has one leg in the ward and one leg in the lab. Over the next 1.5 hours, we will discuss a series of cases which we have managed at Fortis since the past so many years, and which will cover the various aspects of hematology practice in the 21st century. Fortunately, we are joined today by an elite panel of chairpersons together who have decades of experience in management of various aspects of blood disorders. So I would like to kick off the case presentation session, and I would like to invite the chairpersons for the first case. Can you please load the presentation? So I would like to invite Dr. Kunal Gala. He is a senior consultant physician in the Department of Medicine at Fortis Hospital, Mulund. Welcome on stage, sir. I would like to invite Dr. Rajesh Benny. He's a senior consultant in the Department of Neurology at Fortis Hospital, Mulund. And Dr. Charudat Vaiti. He's a senior consultant intensivist in the critical care team at Fortis Hospital, Mulund. So now I would like to call upon our dynamic medicine resident, Dr. Asif Kalam, to proceed with the first case presentation.
Thank you, sir. Good morning, all. Myself, Dr. Asif Kalam. I'm a second year medicine resident at Fortis Hospital, Mulund. I'm hereby presenting a very interesting case, which we titled actually "Blood with Brains." Here, there is a 21-year-old young man with no past history of medical or surgical illness. Yeah. Here is a 21-year-old young man with no past history of medical or surgical illness, presented with complaints of 2 to 3 episodes of transient memory loss and inability to speak over last 7 days. And there was spontaneous bruising over the right thigh, developed 2 days prior to the admission. There was also low-grade fever spikes since 2 days. So he was taken to a nursing home with these complaints and found to have severe thrombocytopenia there. They did a dengue malaria test and they were negative. He was started on injectable dexamethasone and injectable optineuron there, but the platelets continued to worsen. So he was transferred to our Fortis Institute of Blood Disorders for evaluation and management. At Fortis, the patient, he was conscious oriented with no obvious neurological deficits, but there was the BP was on a slightly higher side, 160/90, and there was no lymphadenopathy or organomegaly. His MRI brain with angiography was done, but it was unremarkable. 2D echo suggestive of no regional wall motion abnormality, and the EF was 60%. He was observed in the ICU with pending further investigations. Here's the investigation chart, which showed anemia of HB 9.7 with thrombocytopenia. Platelet was 16,000. MCV was 102. Neutrophilic 90% neutrophils with normal WBC count, but his LDH level was high, 1199, and his vitamin B12 level was more than 2000, which maybe because of he received injection vitamin B12 in the outside hospital. His bilirubin level was high, 3.55, but indirect hyperbilirubinemia was there, 3.2. His creatinine was normal, his serology was negative, and his coagulation profile was negative, ruling out DIC. So the investigation showed hemolytic anemia like picture with thrombocytopenia. The possibilities at this stage were megaloblastic anemia, microangiopathic hemolytic anemia, or acute leukemia. We did the direct comb test, which showed negative, ruling out any autoimmune pathology, and the peripheral smear showed very scanty schistocytes, less than 0.5%. The bone marrow analysis with flow cytometry was done that ruled out leukemia, and the CT imaging ruled out other solid organ abnormalities. And we sent the ADAM TS13 level to Bangalore and ICMR. We continued the optineuron, and the patient was closely monitored by neurology and ICU team for any worsening. This slide shows the serial monitoring of the peripheral smear of the patient. In the day one, there were only very scanty schistocytes with some megaloblastic changes. Here the platelet count was 16,000 and the LDH was 1199. On day 3, there was misleading partial improvement, but the schistocytes level were less than 0.5%. The patient was on optineuron at this point of time. The platelet count was 24,000, slightly improved, and the LDH was 950. On day 5, there was sudden neurological worsening of the patient with seizures, and the schistocytes level jumped to 4%. 2000, and the LDH also jumped to 1570. There was also acute kidney injury happened to the patient also on day 5. In view of the deteriorating neurological condition, the patient got intubated, and we immediately started plasma exchange at 8 p.m. in the night on day 5 itself. After 2 days, we got the ADM TS level, which was less than 1%, suggestive of thrombotic thrombocytopenic purpura. And the plasma exchange continued daily for 7 continuous days. Strict replacement was done with 1:1 plasma, almost 5 to 6 liters plasma daily. After 5 days, FFP had to be sourced from blood banks in Pune and Nashik, as we had exhausted the available FFP stores in Mumbai. This is a picture showing the plasmapheresis plex managed by our transfusion medicine team, Dr. Ledith and Dr. Alisha. Here we can see the hemolyzed plasma. The patient is managed excellently by our ICU team. He was extubated without complications on day 3. Gradually, his LDH level improved and the platelet count recovered to 222,000. The plex was continued on alternate days as there was fluctuations in the platelet count. He was also initiated on steroids, weekly monoclonal antibody rituximab, and a cyclophosphamide once in 2 weeks, as it was clinically behaving like a refractory TTP. He was discharged after plex stopped on day 15. So he was followed up with the hemolytic parameters like bilirubin, retic count, and haptoglobin, which became normalized within 2 weeks. He completed the rituximab and cyclophosphamide course on daycare basis, and the platelet count was holding steady since last 7 months. He is now off antiplatelets, and he has resumed college and is now on a regular fitness regime. So the early referral to the higher center and a prompt initiation of the plasma exchange is the key. My take-home messages include hematological conditions affect nearly every organ of the body with varied and confusing clinical picture. TTP is a life-threatening disease without any if TTP is life-threatening if there is no without treatment. The partial treatment leads to avoidable delays. As in this case, the patient has received steroids outside hospital. So avoid treatment until a reasonable diagnosis. If there is a suspicion of TTP, refer immediately for plasmapheresis. The correct technique of the plex is the key to success for the treatment. So the difference between normal life and death in TTP lies in optimal treatment in first 2 to 3 weeks. Thank you.
Thank you, Dr. Asif, for the wonderful presentation. So now I would like the chairpersons to share a few comments. I would request Dr. Kunal sir to share his views and experience as a primary care physician in managing patients with suspected MAHA who are about to get sick, who come to his outpatient practice. Mike. Right.
So, very commonly we see a lot of patients coming with fever and thrombocytopenia. Now, as far as this case was concerned, he did. We have an initial DDs of maybe a megaloblastic anemia because of high MCV as well as low platelets. And then, as he was there in the hospital on day 4, he threw a seizure. So something like an microangiopathy with anemia, with thrombocytopenia, with a CNS involvement. Probably the differential comes between HUS and a TTP.
Thank you, sir. So now I would move on to our hematoneurologist, as Dr. Sanyal calls him, Dr. Benny. Sir, how would you describe the intricate relation of blood with brains in your neurology practice?
Okay. First, I'll like to address this case because my friend Kunal involved me very early into the illness because he did have a neurological syndrome to present with mild fever. He was episodically becoming confused and we could not place what he was having. We thought that they are complex partial seizures. We had put him on anti-epileptics. But the worrisome problem was that 2-day history of mild fever and the thrombocytopenia. And back of my mind, I was thinking in terms of viral encephalitis. Then I was thinking in terms of autoimmune encephalitis. But that platelet kept on bugging me. Then this COVID, the dengue which was going around, I thought whether it is some form of this dengue or COVID. And obviously all that turned out to be negative. What kept on bothering us because the platelet kept dropping and we are very stingy in terms of calling other specialists, which Dr. Sanyal and you will also agree. So me and Dr. Kunal had a discussion and we said this is a time to involve Dr. Sanyal. We did check for peripheral smear for cystocytes. You'll also remember, you were also there. And it didn't show much till the time he threw a seizure. And then we realized something is wrong and we could never do a CSF because his platelet count was always less than 30,000. And that time, fortunately for us, the cystocytes went up and plasma exchange worked like magic. So this is a person who has come a full circle to a normal person to near death to a normal person. I can remember the mother when she left the ICU. So in many years, this is the first female relative who's actually come and hugged me and would not let go of me for the next 5 minutes. She said, because of you all, that my son is walking out again. So that was a wonderful experience. And I have to thank Dr. Sanyal and the hematology team for pointing us in the right direction. This was a diagnosis which should have been completely missed, I am very sure, in any smaller setup because we would have kept talking in terms of infection related thrombocytopenia, sepsis related thrombocytopenia. TTP would have not rung any bell and he would have succumbed. When it comes to neurologist sharing patients with his hematologist colleague, I used to be very, very stingy when I started my practice. I am now almost 1.5 decade into practice of neurology. My first need for hematology was basically for patients with venous sinus thrombosis. And my go-to person was Dr. M.B. Agarwal. And sir was so good. I was in MGM Vashi that time. I was in MGM Kamote. His reports and his opinions he would send by post to my residential address. He would speak to me on the phone. So it was an amazing introduction to how an hematologist already could help your patients. So the first place where we actually call a hematologist right on board, I feel it is a problem which should be addressed by both hematologists and neurologists, is venous sinus thrombosis. Many times we try and treat these patients on our own. We don't know when to send off these patients. Many patients are being treated as protein C, proteinase deficiency. And that's when Dr. Sanyal pointed out that they were being done during the acute phase of consumption. And they are not truly what you call as deficiency syndromes who need lifelong anticoagulation. So the correct dose of anticoagulation, the correct approach to investigations can be done only by an hematologist. So I exclusively involve a hematologist, Dr. Sanyal, early in my cases with venous sinus thrombosis. So this is basically for the bad ones who come to the hospitals. But it is not only these. I also need a hematologist on board whenever I'm dealing with so-called what is called as cryptogenic neuropathy. Like between me and Dr. Sanyal, I mean, I have learned a lot from him. So he used to always tell me, if you're suspecting MGUS or multiple myeloma, don't send serum protein electrophoresis, which many of us neurologists send off. And we tend to miss this slight increase in M band, this light chain abnormalities. And that's the reason why we now started educating our colleagues to always send for immunofixation, which tends to be much more better to pick up this disease. So I have to thank him for that because he's the one who keeps pointing me. And obviously, then you have diseases which are odd presentations. Like he sees patients with leukemia, he sees patients with lymphoma, and then they come with drug toxicities. So because of him, you've been seeing different presentations. So we have had one boy who was being given, I think, methotrexate, and we get a call that this patient has had a stroke in the ward with very classical hemiparetic symptoms, and you do an MRI that doesn't show anything. You see the patient again after 3 hours, the patient is normal, and then we realize that this is methotrexate-induced toxicity. So many such rare presentations is what a hematologist actually tells us to see. But basically, hematology and neurology go hand in hand in most of the vascular pathologies, in most of the neuropathic disorders that we see. So I'm thankful that I have a colleague like Dr. Sanyal who takes away my load in solving this neurohematology issues for me. Thanks, Dr. Sanyal, for that.
And thank you, Dr. Betty, for being available at all times of the day for any complaints that we might be having. Okay. So for Dr. Charu, first of all, I would like to thank the entire ICU team for a splendid job in this case, and also for all our other nightmarish hematology cases with severe neutropenia, where the WBC count is probably zero. The splendid backup you provide allows us to sleep at night after a tough day. Thank you so much, sir. So, what are the procedures and practice that we have adopted in our ICU at Mulund, which enable us to manage such complicated cases?
So, thank you for having me here, Dr. Sanyal and team. Um, coming before I address your question, coming to this particular case, as Dr. Benny was saying, I remember this patient and the family. I believe, it was the single mother who was very, very anxious, and one of our roles is before therapies interventions is trying to think what is going on, because many a times patients who are coming to the hospital, they are in very grievous state, sick state, and they end up to the ICU as a primary place of admission. And the diagnosis at that point is not clear. They have a platelet which are low, and in our Indian setup, the etiology of that is like numerous. You've got dengue, malaria, infective causes, and the thought process that this could be something hematological and involving the hematology team early is something which has to be initiated. And sometimes we are the primary team assessing the patient, and then involving the hematology as a specialty to come up with the workup is something which may have to begin with the ICU. And this particular case, I remember, Kunal was there, Benny sir, and we got Dr. Sanyal's opinion, and we are quite concerned about him, the way he was deteriorating. TTP carries a very high mortality if it is missed, and if in hindsight it looks very, very clear that the diagnosis is there, the therapies are there, and the outcome is excellent. But if you miss that diagnosis, the outcome is worse, and it is death in almost 90% of the cases. So it's important that we pick up those patients early and address, and that is where the role of intensivist is there, to try and think about the diagnostics along with the stabilization of physiology. um, our approach to these patients, they are especially the TTP cases, they have neurological issues. As in this individual, protecting the airway, maintaining the physiology while we come up with the diagnostics, and then able to deliver the therapy are essentially the steps. So nothing unusual there, but the thought process has to come. We had discussion about whether we should sedate this patient, intubate this patient, when we should intubate the patient, and delaying these decisions is not helpful. So timely intervention is very, very essential while the workup is being done. Especially with TTP, our role also comes to vascular access. These patients sometimes may be difficult to get vascular access. The vascular access are important from delivering the plasma exchange. So getting access like dialysis catheters, which we use for plasma exchange, is important, and getting them without any complication, especially patients are having low platelets, bleeding risk, concerns about the insertion of the catheter is always there. So doing it safely is one of the rules. Then delivering the plasma exchange with the blood bank team, Dr. Lalit is here. We have got excellent support from him. Plasma exchange, the process itself in a very sick patient may be uh, associated with its own problem, hemodynamic instability, electrolyte exchanges are happening, and then these patients, as the plasma is removed, they are also prone for secondary infections and sepsis. So maintaining the barrier, infection control, and having good hand hygiene practices are very important to deliver these therapies in the ICU. So that is generally what we face with. And one of the important things which Dr. Benny said, apart from TTP, we have dealt with situations where we have unexplained DIC, and we are not very sure whether it is DIC to begin with. Platelets are low, uh, PT is raised, APTT is raised, and we're not sure. And the, having the hematologist come up and give us a conclusion of what exactly is happening with this patient, and then guiding the therapies. We are quite, I would like to thank the hematology team, which we have Dr. Sanya leading in these matters and guiding us with the therapies, especially with very critical patients. Thank you.
Thank you so much, sir. Okay, so I would just request Dr. Agarwal to share his vast experience about such patients and advice to physicians in the periphery when they encounter patients with suspected microangiopathic hemolytic anemia.
First of all, good morning to everybody, and extremely grateful to the Fortis group, the administration, and the Institute of Blood Diseases for this huge honor. Thank you very much. Uh, Dr. Sanyal has brought up and Dr. Hamza has brought up a very rare case. So, as there are a lot of community doctors, I must say that this is a rare entity. Even for the specialist, don't think of it left and right. Because if you overdiagnose it, then as you just mentioned, you will do plasma exchanges on people who are not TTP. And you just heard how difficult and how complicated the plasma exchange can be. I must say today the consultants, the intensivists, the nephrologists, the neurologists so worried about TTP that plasma exchange is being overdone than underdone. So I'm just putting it the other way because in the hospitals, one gets scared because you've been taught, do the plasma exchange, do the plasma exchange the moment you think of TTP. So don't overdo it because it's a complicated procedure. And if I look at my back last couple of years, I have said no when they've done one plasma exchange on the previous night, that you stop it because there is no definite evidence that this is TTP. That's one. Number two, again in the community and the say family doctor and the physician, how do you diagnose this rare TTP? As was mentioned, platelet drops left and right. Fever, very common. So somebody's got fever, somebody's got low platelet. In that, to pick up a case of TTP from, what should I say, lakhs of patients. So you should have evidence of hemolysis. And what is that evidence of hemolysis? Hemoglobin is 11 and not 12 in a woman. This is a disease of adult women. This is a rare thing. You got a boy. This is a disease of adult women. 9 out of 10. They are very unfortunate. They get all immunological problems. So then you see this, hemoglobin is 11 and not 12. Retic count is 4%, 5% and not less than 2%. Bilirubin is 1.5 and not less than 1.2. And you saw the LDH, 1000. And the LDH is high. And the SGOT is slightly high. And you do the haptoglobin and that is low. So you documented hemolysis. So you got somebody who's got fever, who's got thrombocytopenia, it can be malaria, dengue, etc., but you got hemolysis. At that time, you look at the peripheral smear, and then you need Sanyal or you need a pathologist or you need a technologist who can see this. Then you don't want to miss even that one cystocyte. So you got RBC fragmentation, which is a must. Once you saw that, you say this is not DIC, and somebody rightly pointed out that DIC is there. Intensivist just told us left and right. So from that DIC, you want to pick up now a TTP. The PT has to be normal, the PTT has to be normal, the fibrinogen has to be normal. Then you think of TTP. So on one side, malaria, dengue, one side DIC, one side so many other things happening. And on that ocean, you have to pick up one case where hemolysis is due to RBC fragmentation, there is no DIC, and platelet counts go below 30,000. The platelet count is 80,000, 90,000, 1 lakh, don't think of TTP. So that's the kind of patient you are doing this, and then collect the blood for ADMTS. Once you do plasma exchange, you can't do ADMTS. So because you don't know after 5, 6, 7 days, continue, don't continue, so you need ADMTs. The last thing I want to mention, which probably because of the time shortage, we didn't discuss why are we doing plasma exchange. So we are removing von Willebrand factor multimers, which are not being broken by lack of ADMTS. So removing that and supplying ADMTS. So actually you are doing plasma exchange as the outcome of this disease. And you are hitting the disease itself by steroid and by rituximab. And because it's an autoimmune disease, it's notorious to recur. So I'm not sure how long you have followed up this boy, but you may see this boy after 3 years, 5 years, 10 years with another episode, another episode, another episode. Or he may develop chronic neurological problems, chronic nephrology problem, chronic cardiac problem. He may come to some cardiologist with some chest pain or some cognitive dysfunction or some little nephropathy or something like that because he is getting that problem off and on of thrombi. So he has to be followed up with this ADMTS level off and on for many, many years. And some of these patients require rituximab periodically to keep this process under check. So these were a few additional things that I could think of. Most important is it's rare. So you need somebody who can diagnose it for you. But you have to refer the patient to that guy. Thank you.
Thank you, sir. So fortunately, this patient has a very loving mother who's going to bring him for follow-up for years.
I do ADMTS, that is.
So I request the chairpersons to please join the audience as we proceed with the second case. I would like to invite on stage our chairpersons for the second case, Dr. Anita Matthew, madam. She's a senior consultant in the Department of Medicine at Fortis Hospital, Mulund. Dr. Naresh Mehta, sir, he's also a senior consultant in the Department of Medicine. And Dr. Shobha Itolikar, she's a senior consultant in the Department of Medicine. I would like to call Dr. Nishiganda Pol to proceed with her case presentation.
Good morning, all. I'm Dr. Nishiganda. I'm here to present a second case of this session. My case is about the unwelcome guest. This case is about 58 years old male from Raipur. He is known case chronic liver disease. He referred to Mumbai for liver transplant. There is no history of alcohol intake, but there was significant history of weight loss of around 20 kgs in last 6 months. He had episode of massive hematemesis after admission. Post stabilization, active varices are tackled by endoscopy. His CT abdomen was done. His CT abdomen is suggestive of hepatosplenomegaly with chronic portal vein thrombosis and portal hypertension. His CBC done during hospital stay with suggestive of severe anemia with hemoglobin of 6.8 grams and moderate platelet thrombocytopenia with platelet count of 65,000. His WBC count was about 14,000 and his peripheral smear is suggestive of leukoerythroblastic picture with multiple NRBCs and teardrop cells. At this point, patient was referred to hematology for further evaluation and management of the thrombocytopenia. His LDH level was 978 and ANA negative. His bone marrow aspiration and biopsy was done. As seen in image A, His biopsy was suggestive of grade 3 fibrosis. His further evaluation was done. His JAK2 V617F mutation was positive. For him, hematological diagnosis was JAK2 positive primary myelofibrosis with portal vein thrombosis and portal hypertension. His NGS study didn't reveal any additional mutation at baseline. He was classified as deep stage intermediate 2, and further discussion of bone marrow transplant was done with him after improvement in general condition. For him, management of portal hypertension was optimized with carvedilol and diuretics. He was started on JAK2 inhibitor, that is ruxolitinib, in view of constitutional symptoms and massive splenomegaly. Doses are titrated as per platelet count. Gradually, his condition improved, and patient was able to return to hometown after a month. After 1 month follow-up, patient symptomatically better, his appetite was improved, and no further episodes of hematemesis. In 6 months of follow-up, patient improved symptomatically, weight gain of about 8 kgs, clinically reduced hepatosplenomegaly, and platelet count was improved to more than 1 lakh, and his Jacobite dose was increased. His CT spleen volumetry was done by Dr. Rajat Bhargav at radiology department in Fortis Hospital, Mulund. His spleen volume was about 4,870 ml at the beginning of the treatment, which reduced to 1,640 after treatment. It is objective method to monitor response to Zakavi therapy. There is a game changer targeted therapy available in 21st century. Medicines are working as miracles. Overnight improvement in prognosis from dismal to excellent in cases like CML, APML, myelofibrosis, like malignancies. Exciting new time for patient management. Most hematological malignancies are now curable. Most patients with benign disorders like hemophilia, sickle cell disease are live normal and productive lives. Some of benign and malignant disorders are treated with the game changers medicines like rituximab in B-cell malignancies, venetoclax in AML, ruxolitinib in myelofibrotic neoplasms, ibrutinib in CLL, and imatinib, dasatinib, nilotinib in CML. Backed by powerful clinical studies, these molecules are transforming hematological practices like never before. From this case, the take-home message is like all patients with chronic splenomegaly should be evaluated to rule out underlying hematological disorders. Splenectomy is almost obsolete in current hematological practices. Providing treatment in hematological disorders is rewarding. If not cure, we can significantly improve quality of life. New molecules are being introduced every day. Incurable disease today may be completely curable tomorrow. Thank you.
Thank you, Dr. Nishiganda, for the insightful case presentations. I would now request our chairpersons to discuss about the findings in this case as well as their experience with management of patients with refractory anemias.
In this particular case, it would have been probably pretty easy to miss out had it not been the hemat consult here. It would have been probably, thought of a run-of-the-mill cirrhotic. I think the patient did not have cirrhosis though. Yeah. So probably what clinched the whole thing was a portal hypertension and the fact that he had a portal vein thrombosis without really having a liver involvement with a massive splenomegaly. I think that itself was a clincher to the fact that there must be something else which is going on in the background. Uh, so I guess without a hemat consult, this would have been pretty impossible. Most of the times, you would have probably landed up treating this patient with some kind of an anticoagulant or looked around for some evidence of infection or probably thought of like a CML. Uh, I think it was a fantastic case, and I personally do have experience with your department and with Jakavi being used for certain of my patients, and yeah, I agree. It's a good drug.
Thank you so much, ma'am. Sir.
Now, morning, everyone. It has been a very rich and informative discussion since morning. Um, both the topics have been very good, especially the first one was very nice. We do see some problems over here, especially in the geriatric age group also, with a lot of comorbidities and transfusion-related problems. And these problems were very severe, and we had a lot of trouble. And we were sticking to our old guidelines, which were there till the arrival of Dr. Sanyal, who has been the brightest shining star of the Fortis horizon. And other than being a gentleman and a good person, there is only one disclaimer. He's a good friend, and he told me to say all this.
Thank you, sir. Dr. Chopra, madam, can you please tell us how do you manage patients with multiple comorbidities, especially in the elderly age group, especially if they have chronic hematological disorders like myelofibrosis?
So this was a very good case, very interesting twist. Uh, the emphasis is that comprehensive management of the patient is very important. Here, the patient had been referred for a liver transplant, but there was a twist, and then he was diagnosed to have a myeloproliferative neoplasm, and then went on to receive a game changer drug. So, in short, he was spared the trials and tribulations of a a major surgery like a liver transplant, because life is not easy after that, also. So, yes, so comprehensive management is important in the sense that we also have to pick up comorbidities like diabetes, hypertension, and other vascular risk factors like dyslipidemia. Patients of this kind of disorders generally present in this fifth or sixth decade of life, when they might be having pre-existing diseases, or they might develop these diseases during the course of treatment with drugs like steroids or other immunosuppressant drugs. If these are not optimally managed, then there might be a unfavorable outcome. Like in case of diabetes, fulminant infections might occur. In case of diabetes and hypertension, thrombotic and hemorrhagic episodes might occur. Likewise, these diseases might also impact the outcome of the hematological disorder. So optimal management, early identification and optimal management of these diseases will be very important.
Thank you, ma'am. So I would like to ask sir a question with his permission. So being relatively young, I have seen the benefits of targeted agents like ruxolitinib. So I wanted to ask you, how was the practice before these drugs were available, sir? How we used to manage those patients, and what was the difficulties at that time?
So thank you, Dr. Hamza, for that question. So when I began my hematology, it was very simple. Iron, B12, folic acid, steroid, blood transfusion. That's the end of Dr. Agarwal. It was that simple. And that's why probably you were not excited to take up hematology. And had hematology remained in the background, and it did remain in the domain of a pathologist to make good diagnosis with clinicians offering nothing. Today, of course, it's the opposite. The last slide, which the case presentation showed you, gave you the list of targeted agents. So that probably is the answer, what we used to do. It was very simple. You could do it in periphery. You could sit in Kandala and do this because you could only prescribe these 5 things. I have to say something about this patient, and that's a request to you, the administration head. There was one lady, Dr. Annie from UK. And my friend, who was a clinical hematologist, he said, you invite her for your teaching program. I said, what does she do? He said, she does morphology. This was a new term to me. I said, what else does she do? He said, she does morphology. I said, morphology means what? He said, she comes at 9, she leaves at 5, and throughout that time, she looks at the peripheral blood film, she looks at the reticulocyte slide, she looks at the bone marrow aspirate, she looks at the bone marrow imprint, she looks at the bone marrow biopsy. She is a morphologist in the department of hematology. When she came here, I occupied your 8 hour duty. She said 8 hours falls site in that peripheral blood film of the first patient, and you're searching for a normoblast or a myelocyte or a metamyelocyte or a teardrop poikilocyte in this so-called case of cirrhosis. Dr. Sanyal, Dr. Hamzat, and me are useless if the diagnosis is wrong. We are very privileged. We are in the city of Mumbai, where we get fantastic diagnosis. The pathologist remains a little bit in the background. The credit goes to the clinician. And the credit to the clinician came because the right diagnosis was made in the lab. And the starting point was the peripheral blood film. A cardiologist sees the ECG. A chest fellow looks at the X-ray. Dr. Beni goes probably to the CT scan, MRI, looks at those plates and makes a diagnosis. But when it comes to hematology, very often it is left to the technologist. And he is bombarded with 100 types of work. He's not a morphologist. So in your Institute of Blood Disease, you need a lady or a man full-time doing morphology. And just see how the diagnosis of all the departments will totally change. Hematological diseases are very common and missed. And I think a penny spent on the diagnosis saves thousands of rupees. As was just mentioned, if this patient would have been transplanted, what kind of mistake must have happened? And the last thing is every case of portal vein thrombosis requires a JAK2. Every case. Portal vein thrombosis, splenic vein thrombosis, mesenteric vein thrombosis, hepatic vein thrombosis, all of these are presenting manifestation of a myeloproliferative disease. If you don't do JAK2 or there are some other mutations, then you're going to miss the diagnosis. Thank you.
I would like the chairpersons to now please join the audience as we proceed with the third case. So I would like to invite on stage our chairpersons for the third case, Dr. Kaushik Bhojani, sir. He's a consultant rheumatologist at Fortis Hospital, Mulund. Dr. Atul Ganatra, sir. He's a senior consultant in the Department of Obstetric and Gynecology at Fortis Hospital, Mulund. And Dr. Sangeeta Raodev, she is a senior consultant in the Department of Obstetric and Gynecology at Fortis Hospital, Mulund. I request Dr. Nayan Raj to proceed with this case. Dr. Nayan is one of the sincerest residents in the Department of Medicine, and I would request him to please come to the stage and proceed with the case presentation.
Thank you, sir, for the nice introduction. Good morning to panelists and all judges. So, my topic today is thrombosis in obstetrics. 32-year-old lady hailing from Jamnagar, postpartum stillbirth 10 days back, presented with sudden onset of painful swelling of left leg since 3 days, breathlessness in 1 day. She was brought to ER with severe chest pain, with hypotension 80 over 60. Saturation was 86% on room air. Respiratory examination was unremarkable. ECG shows sinus tachycardia with elevated trophi. Urgent CTPA was done in ER, which shows massive bilateral pulmonary embolism and left iliofemoral DVT. She was immediately shifted to ICU, thrombolized with alteplase. Post thrombolysis, she was started on therapeutic dose of anticoagulant with enoxaparin. Over the next 48 hours, she was stabilized and hypotension resolved. Symptomatically, she was better with no chest pain. She was shifted to ward and referred to hematologist for evaluation of thrombophilia. Obstetric history, she was married for 7 years, visited multiple obs and gynae specialists at hometown over the years. His first, second, and third pregnancy, there was spontaneous abortion at 12 weeks, 10 weeks, and 9 weeks. In fourth pregnancy, there was no fetal heart sounds and he has to underwent MTP. In the fifth pregnancy, the current one, she was treated with intermittent low molecular weight heparin at low dose throughout pregnancy, which was stopped at 28 weeks due to some bleeding. Stillbirth at 31 weeks of pregnancy. Patient was psychologically devastated, but husband was very supportive. She was stabilized over next 3 days and continued on optimal hydration and therapeutic anticoagulation. Thrombophilia workup was planned and timed to prevent false negative reports due to interaction with enoxaparin. Help from a counselor was obtained in order to deal with psychological trauma. Thrombophilia workup showed ANA 1 plus, which was not that significant. Lupus anticoagulant was present. Anticardiolipin IgM was positive. Anti-beta 2 glycoprotein IgM was positive. With a negative anticardiolipin IgG, anti-beta 2 glycoprotein IgG, and factor 5 Leiden negative. Factor 5 Leiden was also negative. Protein C, protein S, antithrombin 3 levels not sent due to active thrombotic states, and we do not send antiphospholipid antibody routinely for APLA diagnosis. Strategy, final diagnosis was suspected primary antiphospholipid antibody syndrome with a triple positive, deep vein thrombosis, pulmonary embolism, query APLA associated pregnancy loss. Rheumatology review was obtained and she was started on hydroxychloroquine. Therapeutic anticoagulant was continued and started on warfarin. Need for lifelong uninterrupted anticoagulation was stressed. She and her husband were counseled to defer planned of conception by 6 to 12 months for effective management of DVT and pulmonary embolism. Follow-up at third month, APLA workup was repeated after 12 weeks, persistently positive. Warfarin was strict INR monitoring was continued. Ultrasound shows partial resolution of thrombus with good recanalization. At 6 months, CT imaging showed near completion resolution of pulmonary embolus, venous Doppler of lower limb, complete resolution of iliofemoral thrombus, and D-dimer were normalized. Follow-up, after 6 months, warfarin discontinued for a brief period. Protein C, protein S, 83 levels were normal. Conceived a year later and was managed with therapeutic LMWH throughout pregnancy and in the postpartum period. She was blessed with a baby girl in 2020. Antibody syndrome are produced by beta cell in the endothelial cells. Antiphospholipid antibody bind to the open beta to GPI. Activation of inflammatory cells and endothelial cells in the endothelial cells leads promotion of coagulation, interference with trophoblast and decidual cells. Through multiple mechanisms of antibodies in activity results in inflammation, vasculopathy, thrombosis, and pregnancy complications. Take-home messages. Recurrent pregnancy loss may be a manifestation of an underlying thrombophilic condition. Inherited thrombophilia is extremely rare in Indian population. Disproportionate use of anticoagulation in pregnancy without appropriate evaluation should be discouraged. In most cases of bad obstetric history, properly timed investigations lead to diagnosis. Management of anticoagulation in pregnancy is a skill gained by experience. An appropriate team, including a hematologist, rheumatologist, and led by obstetrician, will definitely lead to good news. Thank you.
Thank you, Dr. Nayan, for his enlightening case presentation. At the end of the day, we all like a happy ending. So I request Bojani sir to share his thoughts on how we can best coordinate different specialties to give good outcomes to patients with complicated connective disorders and bad obstetric history.
Thank you, Hamza, for the question. So the first and foremost thing to start with is the fact that why waste time in investigation if by definition you know this is a bad obstetric history, you know which side you're going. So we investigate first, we make the patient go through 3 miscarriages, 4 miscarriages, 5 miscarriages, then make the patient undergo a pulmonary thromboembolism before we come around and say that no, this is antiphospholipid antibody syndrome. So by definition, bad obstetric history is 3 first trimester miscarriages. The moment you have that, you know that this patient has a coagulation disorder. So the 4th and the 5th, whatever the patient went through was really pointless. Now, coming to coordination, I've always maintained, and I've been, thanks to the referrals of the obstetricians, more so Atul, uh, I think we've been working together for about 15 years now. And now the data is, sequential data is more than 850 patients. My stand is, first and foremost, where was the clinical examination? There was no clinical examination. We are turning around and saying the ANA 1:41 plus, whether it was positive, whether the APS, whatever it is. I've been maintaining this for quite some time that most of the antiphospholipid syndromes are secondary. They are not primary. Primary is a rare thing to see. How often do you see a primary? So when you turn around and say that the ANA is positive, was it substantiated? Was the clinical examination, were there clinical signs for you to decide that this is primary or secondary? This is the first place where we start. And then we go backwards. So the moment you had the 3 miscarriages is where your antenna are already up. And then you're looking at the fact that some investigations have been done by well-wishing consultants, whoever might have been, and you have an ANA positive, but the clinical examination is lacking and the detailed history is lacking. So somehow we clinicians have gone the diagnostics way. Now, There are certain specialties where, like for example, hematology to start with, diagnostics are imperative. But for guys like us, we are hardcore clinicians. So we start with a history, and then we will decide as to where you need to go and what investigations you need to do. And then after that, to have management. So if you look at that slide which this young boy has presented, a beautiful slide, but nobody bothers to actually read these complicated photographs. And if you look at that, you realize that the complements rise. There has been enough data to prove that antiphospholipid syndrome may not necessarily be a benign thrombotic disorder. It could be an inflammatory disorder. This has been proven on histopathological diagnosis to show that there is no thrombosis. So here you're saying this is a thrombotic disorder which has caused a miscarriage, and you do not see the transplacental thrombosis. So this is where I would need to involve the hematologist. I would need to discuss this with the gynecologist. But the first and foremost thing is starting with the patient. And then we'll decide who to coordinate with. Thanks.
Thank you so much, sir. So I would like to ask Dr. Ganatra and Sangeeta madam, sir, what are the optimal precautions you take when we are planning a pregnancy, a conception, or at the time of delivery in a patient with this chronic hematological disorders like APLA or thrombocytopenia like ITP?
So first of all, thank you for giving me this opportunity, and I'll echo Dr. Benny's statement that uh, I have learned how to read a CBC report because of Dr. M.B. Agarwal. This is my 30th year of practice, and in 1993 and 94, sir used to send us a letter by post because I asked him once, so why do you do that? He said, I'm not sure if the patient will come back and show you that I've sent you a return referral note, and that's why I sent it by post. And I think that is Dr. M.B. Agrawal. And today, if I stand with any position of my knowledge in hematology, it is because of Dr. M.B. Agrawal. And as far as repeated abortions is concerned, Dr. Bojani. Our textbooks say 3 abortions, don't do anything. And I cannot tell my patient that you wait till you have 3 abortions and then I will start investigating you. And that's why I was labeled as an expensive gynecologist very early in practice. The modified Sapporo's criteria very, very clearly say that any woman who has an abortion after 10 weeks of pregnancy needs investigations. And thanks to Dr. Sanyal, Dr. Agarwal, and Dr. Kaushik Bojani, that I've now written a small monogram for Foxy. I was the vice president last year on thrombophilia and pregnancy. And I think this is a good platform to say that now that we have Dr. Bojani here, we must come out with a package of tests for repeated abortions because they are expensive tests. This morning I was delayed because we managed a patient of lupus nephritis in pregnancy. She had multiple losses. With great difficulty, we managed to get her pregnant by IVF, but unfortunately we lost her because of a lupus flare. So I think this is a specialty that has a lot of weight, and there is a huge demand of patients because they come to us from all over India now and abroad as well. Dr. Bojani has just seen 3 of my international patients. So I think this is a fantastic opportunity, and now that we have Dr. Sanyal as the captain of this ship here, I think we must come out with good packages. Another important point I think that we need to highlight is I had a patient who got to me a few BOH profile blood reports. The sample was collected in Thane, and then the sample was sent uh, to Metropolis head office. So I spoke to the Metropolis person there. Dr. Sushil Shah, the owner, happens to be a dear friend. So his doctor as to you, if you have a sample for citrate bulb, the plasma has to be separated in 15 minutes. So how do you manage this? Because the patient says, I stay in Andheri, my sample was collected in Thane, and then sent to Vidya Vihar. So I think they said that they put it in dry ice, they freeze it to, minus degrees temperatures, and then they sent it. I think these are some important things that I've been talking all over the country for Foxy and educating my colleagues for simple things like not to put a tight band, collect blood, send it immediately. I think this is something that we need to kind of highlight and come up with this, and I'm sure this has a great future. Thank you.
Thank you, sir.
Um, Thank you. Very. This was a very a good case to discuss because I would say that as a gynecologist, we do come across recurrent pregnancy loss patients, and taking a careful history would have helped this lady, which she had gone through so much of losses, and then the complication of pulmonary embolism and DVT. This could have been easily prevented. Um, that's why when such a patient comes to us with recurrent pregnancy loss, careful history taking is very, very important. Many a times, women themselves are not aware of the loss, what has actually happened. So spending time with them, taking a careful history, counseling them helps. uh, Such patients obviously need a very good team approach, and we at Fortis with Dr. Sanyal sir and Dr. Kaushik Bhojani, we are really privileged so that we can manage such patients very comfortably. And in this particular case, I would say, especially when I like to see the patients in the preconception period, start them on with aspirin, folic acid, and then in the pregnancy, with the help of the team, continue them with the heparin and low molecular weight heparin especially.
Thank you so much, ma'am.
I think there was a time when we came in practice in 93, 94. The mother-in-law would come with her daughter-in-law and say, "Bacha acha hona chahiye." I think there's a huge paradigm shift now. The second half of the decade said healthy mother, but now we are at a stage when we say healthy woman. Healthy woman will become a healthy mother and will give birth to a healthy baby. So I think the onus is to get these women, do adequate pre-conceptional counseling, see that they eat well, they have their basic investigations. So if the woman is healthy, then the mother and the baby will be healthy. Thank you.
Thank you so much, sir. Sir, so in your experience in all the patients which you have managed with thrombosis, so how common is inherited thrombophilia in India?
Hello.
Thank you. Sorry. So, both this case and the question, again a woman, again a young lady, again thrombosis. I think Sanyal is a little biased with thrombosis. First patient thrombosis, second patient thrombosis, third case thrombosis. It's very important. Thrombosis means you think of heart attacks, you think of stroke. But as a hematologist, we talk about the veins, 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 and veins. And of course, the placenta and the small vessels. Thrombophilia is the term coined by the hematologist because these are essentially venous prothrombotic disorders. And you're absolutely right, genetic predisposition to thrombosis is sort of a disease of Caucasians. It is much less common in India. So antithrombin 3, protein C, protein S that we talked about, you see occasionally. They're there, you see them occasionally. Factor V laden, etc., you see them occasionally. Prothrombin mutation, you don't see at all, and that completes the package of inherited thrombophilic disorders. In pregnancy, the only test that you need is antiphospholipid syndrome. You don't even need all this. Even if I document antithrombin 3, protein C, protein S, factor V laden, I cannot put it together with the fetal losses, etc. So the only disease you need is antiphospholipid antibody syndrome. Again, a disease of young women, so you have to do this investigation. And here there is a little problem. You need a hematologist because there is a test called lupus anticoagulants. And that's not done by routine labs. And that cannot be done on transported samples. And you beautifully brought out the concept of transported sample missing the diagnosis or over-diagnosing something. Lupus anticoagulant is a coagulation-based test. And it has to be sort of blood collected at the site and processed. While anticardiolipin antibody, beta-2-glycoprotein, you can do anywhere. And the last thing I want to say is, as you mentioned, healthy woman, healthy child. I don't know, the things might have changed, but I still see the mother-in-law asking for only one thing, that when will I have my grandchild? So I don't think we have moved from that in India, and at least not the type of practice I have, so it still remains. It's a disaster sometimes for a woman who has got prothrombotic disorder to allow her to have the next baby. In 2022, it may look very harsh that you're not able to tell the mother, okay, nothing will happen to you and you will have a baby. But when you go through these cases after cases, and then you realize that some mother died somewhere. Despite all your attempts, despite whatever you could do, all your anticoagulation, this, that, etc., she died. So you have to prognosticate this APS. In medicine, prognostic factor, predictive factors are very important. So there is a woman who's got this syndrome and who can succumb. Now, for that lady to satisfy the mother-in-law to have a baby, of course, the business of a gynecologist may be less, but is difficult to justify because her life is more important than having a grandchild in the family. So it's a social medicine, but it's very, 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 very important. Your answer was very straightforward, but the other part I think was more important. Thank you.
Thank you so much, sir. I request the chairpersons to please join the audience. Okay, so now we have a little change of pace from all the adult patients to a pediatric patient. So I would like to invite on stage our chairpersons for the third case. So unfortunately, Jaisal madam was not able to be present today because she's busy managing a sick child in the NICU. I would like to invite Dr. Prakash Vaidya and Dr. Rajan Doshi, senior consultant in the Department of Pediatrics at Fortis Hospital, Mulund. Please join us for this case. So then I would like to request Dr. Sanyal to be a chairperson, please. Okay, so Dr. Ann Thomas, can you please join us on stage for the case presentation?
Good morning. I'm Dr. Ann. I'm a pediatric resident and I would like to present this case titled A Minor Error. So as we go through this case, we'll find out what the minor error was. This is a 14-year-old boy who presented with complaints of high-grade intermittent fever and cough with expectoration for 5 days. He also had a history of easy bruising with minor trauma, and that is a history of 3 months. Associated with this, he used to have 2 to 3 episodes of nosebleeds, which lasted for more than 5 minutes each time. So for these complaints, he was seen by his pediatrician and found to have severe thrombocytopenia. And for this, he was referred to hematology. Now on admission, he was febrile and he was mildly tachypneic. And his CBC showed a HB of 7.8, WBC count of 1,200, an absolute neutrophil count of 120, and platelet count of 14,000. Now, his chest x-ray was done because he was having fever and cough as primary symptoms. Chest x-ray, as you can see, showed a left lower zone pneumonia. So a diagnosis of pneumonia with pancytopenia was made, and he was started on IV antibiotics with a pending evaluation for pancytopenia. Further investigations revealed that he had a low corrected retic count, 0.4%, while the other investigations like liver function tests, creat, and viral markers were negative. ANA was negative, DCT was also negative. With IV antibiotics, his clinical condition improved in the next 48 hours, and there were no fever spikes and respiratory distress reduced. Further detailed physical examination showed that he had a hypoplastic left great toe, he had bifid toes in both legs, and he had a high arched head. He had deformities of the pinnae and a chest wall deformity. So because of physical anomalies, an ultrasound abdomen was done to rule out any intra-abdominal anomaly, which showed a horse-shaped kidney. There was no hepatosplenomegaly. In view of a clinical picture of pancytopenia and all these physical deformities, bone marrow examination was done, which showed a hypocellular bone marrow biopsy with predominantly plasma cells and lymphocytes. And PNH by flow cytometry was negative. So this was a young child with significant physical deformities and a hypocellular marrow. So a strong suspicion of inherited bone marrow failure syndrome was made. Cytogenetics was done as a result, and stress cytogenetics showed that there was increase in spontaneous as well as mitomycin-induced chromosomal breaks as compared to the normal control. So a next generation sequencing was done, and next generation sequencing showed a single nucleotide substitution in the exon 11 of the FANCA gene. And that brought us to the diagnosis of autosomal recessive Fanconi anemia with very severe aplastic anemia, multisystemic congenital anomalies. Now, for this, the patients were counseled for bone marrow transplant and further management. However, he did not have a sibling donor, a HLA matched sibling donor, and they had financial constraints, and hence they deferred the transplant. So the antibiotic course was completed, and he was sent home on anabolic steroids. He was followed up regularly for 4 years, and over the 4 years, his blood counts partially improved because of the effect of anabolic steroids, and he was free of PRBC or platelet transfusions. He was vaccinated as per protocol, and infections were managed aggressively over the next 4 years. But the sad part was, unfortunately, at the age of 19 years, he developed squamous cell carcinoma of the anal canal, and he succumbed to it. So Fanconi's anemia is a disease with protein manifestations. It is an autosomal recessive genetic disorder, and one of the most striking features in the OPD will be a child with short stature. Short stature, strabismus, low set ears, plus or minus infections of the ear and deafness, and abnormal thumbs or absent thumbs with hypopigmentation and freckles. So these are some of the common clinical features of Fanconi's anemia, and this is mostly commonly seen in Ashkenazi Jews, very rarely seen in Indians, and treatment is bone marrow transplant. So what we need to remember from a case like this is that inherited bone marrow failure syndromes are pre-malignant conditions, and they need long-term follow-up and careful management for regular screening for malignancies. Minor errors in DNA repair pathways lead to catastrophic clinical manifestations. So this was a small error in his DNA repair pathway, and he succumbed to it at the age of 19. A high index of suspicion to identify patients with characteristic physical manifestations is very important, and encouraging patients with bone marrow failure syndromes to undergo bone marrow transplant for aplastic anemia is important. Also, we need to remember that not all patients with Fanconi's anemia develop solid organ cancers. So that is why we need early screening and experienced surgical team that can handle most of these. And with a very good follow-up, timely interventions, aggressive management of infections, most patients do have a good quality of life. Thank you.
Thank you, Dr. Anne, for her crisp presentation. Yeah, to lose such a young patient, but in such disorders, there is very limited management available. So I would request Dr. Vaidya and Dr. Sanyal to discuss their views about this case and how to manage these inherited bone marrow failure syndromes.
A very good morning. I thank Dr. Sanyal and entire Fortis administration for this privilege I have of sharing the stage. And let me tell you, I've been really privileged to listen to Dr. M.B. Agarwal in KM days when I was a resident and he was a lecturer. And though in his unassuming way, he tells us that it was only about iron and vitamin B, even then he added such a dimension to it that his lectures were, attended so, we were so keen on attending and learning from him. And today, of course, he's a towering personality, but I've been really witness to his amazing progress. So it's a privilege to be here with the same hall with Dr. Agarwal. Regarding the patient, a very interesting case. Uh, in the context of a child with fever, breathlessness, and thrombocytopenia, the last thing we really think of are really things like Fanconi's anemia. We would first think of dengue, we would think of HLH, we would think of something like a parvovirus infection, any of which to a pediatrician, these infections are the one that cause thrombocytopenia, especially in the context of fever and breathlessness and sepsis. So I think the reason this case was picked up was absolutely by being holistic. Because who really notices deformities in a child in the context of a sick child? It's not very easy to say that, okay, this guy has a bifid toe or a small thing. And these are really small pointers to a child who might be having a congenital problem that has led to thrombocytopenia. The other thing is that, yes, today, once having suspected we are on the right track, we do genetic tests. But often today, we are also guilty of asking for too many genetic tests because we use it as a fishing expedition. We think by genetics we'll get a diagnosis. But the whole idea is to first come to a clinical focus and then ask for the test accordingly. And I'm really been happy that Dr. Sanyal has been there with us all the time. And these complicated cases, we have found him greatly useful with all his insight. And I think it was all in all been a very wonderful journey with Dr. Sanyal on board. And we've had a lot of complex hematological cases sorted out in the right way. Thank you.
Thank you so much, sir. Okay, so I would request Dr. Agarwal, sir, to tell us, are there any new recent advances in the management of such patients, sir, which will improve their prognosis?
Okay. So thank you for that question and thanks for presenting this case and thanks, Dr. Vaidya. Yes, KM days were wonderful. I am little blessed that my wife, by qualification, is a MD pediatrics, and she used to work with Dr. Kumta. So there was a genetic touch to her training. In my clinic, each new patient first goes to her, so that she can pick up these kind of rare syndromes. Because physical stigmata is a part of Fanconi's anemia. Fanconi anemia has got three things. One is, of course, our domain, the aplastic anemia. Second is picking up the genetic abnormalities by which you can pick up even at the man at the age of 30 and 40 that this could be a constitutional aplastic anemia. So somebody had said that in hematology you don't examine, we examine. We do examine. We ask the person to strip himself or herself and examine fully. It is extremely important, especially for these genetic disorders. And the third thing is they are highly prone to squamous cell carcinoma. You can't repair your DNA. What can be the biggest curse that the God can give you? That you can't repair your DNA. All of us have things which keep damaging our DNA and you can't repair it. Again, a social message. In my community, we say there is something like a gotra. If the gotra is same, don't marry each other. I think this is a clear-cut scientific message that you'll end up with autosomal recessive disorders. So take care before you marry. If you don't want millions of these rare autosomal recessive disorders in your family. Whenever I see a consanguinity and I see a child suffering, I don't know what to tell the parents because they will live with that guilt for the whole of their life. That because they married within the family, they got this child with this disease. But then that's how it is. Squamous cell carcinoma is, you had it at the other end of the body, but so common in the head and neck area in Fanconi's anemia that you cure a guy of aplastic anemia with all the hassles. The transplant of Fanconi's anemia is a job which only Sanyal can do. Otherwise, you'll succumb to the transplant itself because you have got fragile DNA. These people have to be searched every year for things that is happening, and there's a medical oncologist sitting here in the upper half of the body to look for where the squamous cell carcinoma is developing. A little leukoplakia and you will do a wide excision. Otherwise, that will end up into squamous cell carcinoma there. You can keep doing scopies to look at if there is the slightest suspicion of that the patient can't swallow or there is a difficulty somewhere. So keep searching for this 500 to 5,000 fold more incidence of squamous cell carcinoma. And my patients have all died of squamous cell carcinoma. We have cured them probably of Fanconi's anemia, but we couldn't do anything to prevent this. The only new thing that is coming up is the gene therapy, but like any other disease, you have to just wait and watch when the gene therapy will happen. My message is avoid consanguineous marriages.
Thank you so much, sir. Very practical. So I would request the chairpersons to please join the audience. So I would like to, I request the chairpersons who, for the fifth case to please join us on stage. So Dr. Sanjay Shah, sir, he's a senior consultant in the Department of Medicine at Fortis Hospital, Mulund. Dr. Uma Dangi, madam, she is a senior oncologist at Mulund with us. And Dr. Lalit Dhantole, he's a senior consultant and this thing in charge of the blood bank at Fortis Hospital, Mulund. I request Dr. Alisha Kerkar to please join us this thing on stage. Dr. Alisha is a consultant in the Department of Transfusion Medicine. She is excellent at managing stem cell granulocyte and STP apheresis. And we are proud to say that we have never had a shortage of blood products with Dr. Alisha and Dr. Lalit handling our blood bank. Thank you.
Thank you, Dr. Hamza. Myself, Alisha Kerkar. I'll be presenting a unique case. Believe it or not, I'll prove the title, Wolf in a Sheep's Clothing. 73, we had a case, 73 years old gentleman with a known case of diabetes mellitus type 2, presented with chief complaints of excessive fatigue, dyspnea on exertion since 6 months, history of jaundice, documented weight loss of 8 kgs in last 6 months. Occasionally, there was low-grade fever spikes once or twice a week. He was evaluated by multiple physicians over a period of 4 months. Everyone labeled him as moderate to severe anemia. He had received parenteral iron and vitamin B12 supplements twice, but there was no improvement. Finally, he was subscribed a PRBC transfusion, but unfortunately, blood was not found to be compatible. So they went ahead with DCT, which came out to be positive, and he was diagnosed with autoimmune hemolytic anemia. Then he was immediately started on steroids. He had transient improvement in hemoglobin, but symptomatically he kept on worsening. Persistent weight loss despite high doses of steroid. He was managed with fluctuating doses of steroids for 2 months. But finally, he came for the second opinion to Fortis Institute of Blood Disorders. By that time, but he had uncontrolled diabetes. He had oral candidiasis and significant cachexia. At Fortis, we did the basic investigation, the CBC. The hemoglobin came out to be 8.2, and mainly the lymphocytes was increased to 56%. Mild renal dearrangement was then, that is, creat was 1.7. There was indirect hyperbilirubinemia. There was raised LDH. The retic count was also increased to 4%. There was decreased heptoglobulin less than 0.08, which all indicates hemolytic picture. So the DCT was done, which came out to be uh, positive. The grading was 3 plus. Then we went ahead for the monospecific cards. That is, we generally do, if the DCT is 2 or more, we go for monospecific and we find out which is the antibody. So it was a IgG class antibody. Then came question of primary AIJ, which is very unlikely in elderly. So flow cytometry was done, evaluation of the bone marrow aspirate. In flow cytometry, CD19, CD20 positive B cells with lambda light chain restriction, which indicates monoclonality. Then the bone marrow biopsy was done. CD20 positive B lymphocyte aggregates were seen in the bone marrow. Then we did the CT chest, neck and abdomen. In neck, we found the subcentric right level 2 cervical lymph nodes. Chest, there were no lymphadenopathy. Abdomen, there were multiple enlarged mesenteric and para-aortic lymph nodes. Bilateral subcentric iliac lymph nodes. So the final diagnosis was low-grade lymphoplasmacytic lymphoma with secondary AIJ. So the steroids were tapered down in the next 5 to 7 days. The diabetes was managed in concern with the endocrinologist. For oral and esophageal candidiasis, was treated with fluconazole. Patient general condition was optimized prior to starting the definitive treatment. He was then started on treatment with targeted chemoimmunotherapy with bendamustine and rituximab. Currently, he has completed 3 cycles of the treatment. There has been excellent response to the therapy with no active signs of active hemolysis. Now, in blood bank, exactly what we do for this DCT positive cases. We do the basic blood grouping, we do the antibody screening, that is the ICT, and the DCT. DCT, generally we do it a monospecific DCT, which will not give the antibody, which type of antibody is there. So we then go for a mono, if the DCT is 2 or more, the grading is 2 plus or more, we go for monospecific that. Monospecific that we generally get which type of antibody is there, IgM, IgG, IgA, C3d or C3c. So with that, then again, if the DCT is positive with a pan-reactive ICT, we go for G1, G3 studies, plus or minus C3D. That does not matter. Only IgG should be present to go ahead with that dilution studies and G1, G3 studies. Basically, diet dilution will tell us the risk of hemolysis in the patient. Even G1, G3, because this subtype of IgG are generally causing hemolysis. If the antibody came out to be IgM type with C3d positive or negative, we go for thermal amplitude studies. Thermal amplitude studies, basically we find out the nature of the antibody, at what thermal amplitude it is reactive. And for these cases, we also go for a cold antibody titration. If the titers are more than 1000, we label it as CAD, that is cold agglutinin disease. And additional testing, elution studies and adsorption studies are done. Basically, adsorption studies are done in recently transfused patient, because all hematological disorders generally they are multiply transfused. So it's very it's very necessary to know whether there are alloantibodies present along with some autoantibodies. So we go for elution and adsorption studies. This is the interpretation of that. Gives a picture which type of AIHA is present, whether it is a AIHA, it's a cold agglutinin disease, or a mixed type of AIHA. I have just put the that dilution cards. If the titers in that dilution is less than 1 is to 30, and we say that the risk of hemolysis is less. If it is more than 1 is to 30, we say that the hemolysis is strong. In G1, G3 cards, also there is dilution, but only two, like 1 is to 1 and 1 is to 100. If even 1 is to 1 is present, we say that there is a risk of hemolysis, moderate risk of hemolysis. But when the titers are more, we say that the risk of hemolysis is very high. So this is how we report. Basically, this is the dilution, the titers are less, G1, G3 is generally absent, and there is very low risk of hemolysis. But when you see the primary AIHA cases, we see that the that dilution is, when we go for the titers, it is more than 1 is to 300, which indicates that the risk of hemolysis is more. Uh, Take home message: hematological disorders in elderly, very often signs of sinister underlying disorder may be present, so you should always evaluate it thoroughly. Use of steroids should be in optimal dose and optimal period of time. Any attempt, for every AIHA cases, there should be an attempt to know the nature of the RBC antibody which is present. Alloantibodies are very challenging problem in previously transfused patient, especially the hematological patient, because they are already multiply transfused. So in these cases, if we go for advanced hematological workup, it is always better that we give a phenotype match blood if the alloantibody is present. Thank you. And thank you, Dr. Sanyal, for giving me this opportunity.
Thank you, Dr. Alisha, for highlighting the wolf hiding in the sheep's clothing. Okay, so I request Dr. Sanjay sir for his comments on the case and any such experience in his practice.
Hi, good afternoon, everybody. Before I do any comment on the case, I must thank Fortis and Dr. Sanyal for having such a wonderful session here today morning. I remember when I started my practice, I've been practicing in more than 3 decades, and whenever we would get stuck in our cases of anemia and thrombocytopenia, and for that matter, any of my colleagues, my physicians, anywhere in Mumbai, the only name which would come on our pen is one and only Dr. M.B. Agarwal. And our patients had to go to Dadar to see him. And we would be eagerly waiting for Sir's file. Sir sends a unique file with each patient. And we were 100% sure that when we will open that file, we'll have a 100% clinical diagnosis. Sir will send a brief note on the disease first. Sir will send all the detailed reports of the patient and the treatment guideline, and also mention the contact numbers of the people from where to get those drugs at a cheaper rate for the patients. I really loved those files, sir, when we see those files. And you are really a legend in the field of hematology. And you have been our savior for decades in our practice. And now, since a decade, we have associated with a very close and a very good friend, Dr. Sanyal, and he has really helped us sharpening our clinical acumen on how we look at anemia, how we look at thrombocytopenia, and how we manage our patients. Coming to this case, every anemia is not a B12 deficiency or an iron deficiency, and every autoimmune hemolytic anemia is just not steroid and forget. One has to look beyond it. Primary autoimmune hemolytic anemia is not so common. And a patient like this, an elderly gentleman, if you go to the history, he has had a history of weight loss for 6 months. He has been sick for 6 months. He was started on steroid but did not recover, and one has to look for the other causes of autoimmune hemolytic anemia so commonly associated with underlying malignancies. Very well worked up and very well treated, Dr. Sanya. Thank you.
Thank you so much, sir. For Uma, madam, reaching a definitive diagnosis in patients who have been partially treated before and who come to us in the OPD is very difficult. So, how do you handle such cases, ma'am?
So actually, very interesting case, and like Dr. Sanjay Shah mentioned, that it's very important to work up a patient correctly before starting on therapy, especially if the patient is not decompensated with the anemia. It is very important to find the cause before you go ahead with the treatment. And we do see in our practice that many times they come partially treated with steroids, and then you have you may miss the diagnosis. Many times in such patients, what we try to do is, if you do the bone marrow, you send a flow, and now with the newer techniques, you can even detect a very minimal residual disease. So the techniques are so much better that you can sometimes get a diagnosis very easily. But the thing is, if you can't, then it's best to stop the treatment, wait, and then investigate after some time so that you can get the correct diagnosis. In this patient, if you see, he already had a lymphocytosis on the peripheral smear. So that could have actually, clinched the diagnosis that we are dealing with something like a chronic lymphoproliferative disorder in the beginning itself, and started the investigations in that regard.
Thank you so much, madam. Okay, so Dr. Lalit, so basically Dr. Alisha has brilliantly highlighted the approach to antibody detection in AIHA. So I would like to ask you this thing, what about transfusion for patients with rare blood groups, and how do we manage those at our blood bank in Fortis?
So, good afternoon, all. I thank Fortis management for inviting us, and thank you everybody who have actually joined over here in such a good CME. And really congratulate Dr. Sanyal for starting such a good project. So, as of the case is concerned, I would like to point out the case which was being presented. What happens is, to a clinician, giving a report as to direct wound stays coming out to be positive, or the grade of reaction is not the only thing which needs to be done. They need to identify as to what type of antibody is coating the red cell. So whether it is a warm type of antibody or IgD type of antibody or IgM, or complements are being coated. So we try to differentiate it at our lab. And based on that, the clinician decide as to whether it is a cold antibody or a warm antibody, and the therapy is being decided for these cases. As of the rare blood groups are being concerned, so it's actually not a rare blood group. What the thing is, these are high frequency antigens which are actually present in the population. So we all must be knowing as to there are basically the majority of people will be knowing ABO and RH blood group system being a major blood group system. But apart from that, as per ISBT, there are actually more than 40 blood group system which can actually have an antibody. Suppose if there is an immunizing event in these kind of cases. So suppose if the antigen frequency is more than 98%, that means in a population, the antigen frequency is more than 98% and only 2% of the people who are negative for it, they get a transfusion from a positive case, from a positive donor, they might develop an antibody. These are called as uh, blood group systems or rare antigens, high frequency antigens. So we actually need to have a registry for these kind of cases. Say for example, the Bombay blood group registry, the antigen frequency is more than 99.9%. So there are registries available, and I think in Mumbai only 20 donors are actually available for Bombay blood group registry. So we need to maintain these kind of registry, and based on that, we can actually manage these kind of cases.
Thank you, Dr. Lalit sir. So, Agrawal sir, so Dr. Uma pointed out that they missed the lymphocytosis initially. So, what are the other subtle clinical subtle signs in the CB which will point to a serious hematological disorder that we all should know?
Thank you. Brings you back to the basics. CBC, peripheral smear. CBC, peripheral smear. So if everybody is conscious of the simple fact that in CBC there is something abnormal, the peripheral smear is well read and there is something abnormal, pursue it. As I said, autoimmune diseases are domain of young women. So you've got a man and you've got a 73 years of age. The moment it's that combination, you know that this is something more sinistrous. But that's not the age group you get autoimmune diseases. So look for something. And then probably the peripheral smear and the CBC it was very, very staring at you if you are from the field of hematology. That is the answer to your question. I have few comments. So I remember Dr. Pravina Shah is sitting here, my teacher. I did my neurology. Yes, madam. 76, first half, your unit, Dr. Monkar, whom we lost 2 days ago, was my boss. And the case I presented, he looked at me, he said, what did you say? I said, 73-year-old man. He said, 73-year young man. So people like us are very happy when somebody says 73-year-old. No, young man. It's very important that you respect the age. In medicine, we don't do that, but I think that was a lesson I learned in 76. Second thing I learned from Dr. Monkar and Dr. Pravina Shah, an elderly man, and you know how a resident is? Discharge the patient so that your workload is less. An elderly man, he would say, what happened to that man? He went home yesterday. You discharged him. We had finished with things. We had not finished with anything. And I learned one thing, that till you come to a diagnosis, don't give up. And that diagnosis has to be pursued. Today you are lucky. PET scan, MRD, molecular testing, NGS, but starts from the physical examination. And Dr. Pravina Shah, I cannot remember that boy with Wilson disease who was in the ward for 2 years. KF ring was the diagnostic thing. So examination. And I don't know whether this man had some lymph nodes or liver, spleen, etc. or not, but something would have picked up that this is something underlying, as was the preface. But the last thing is on the treatment of this. We talked about targeted therapies. This patient is MYD88 positive, lymphoproliferative disease with autoimmune hemolytic anemia. He can probably do very well with ibrutinib, both his disease as well as his complication. So we will be discussing probably, and we've discussed in the morning also, targeted therapies have made their inroads ahead of chemotherapy, and they can be done at home. They can be quite beautiful. Today we have generics, so the cost effectiveness is also there. That can be a new dimension to the treatment. Thank you.
Thank you so much, sir. So I would request the chairpersons to please join the audience. So we are now going to proceed towards our final case. I would like to invite the chairpersons, Dr. Pradeep Shah sir, Dr. Manish Tolikar sir, and Dr. Rajesh Kajra. They are senior consultant physicians in the Department of Medicine at Fortis Hospital, Mulund. Sir, please. So I am thankful for the opportunity to present this case myself. My case is titled 50 Shades of Grey. So this was a 23-year-old boy. He presented to Fortis ER in September 2021 with complaints of gum bleeding since 2 days and multiple ecchymotic rashes over the chest, neck, and lips. There was no history of fever. There was history of an abdominal distension with severe weight loss since the past 6 months. He gave a history of such episodes every 5 to 6 months since many years. These were associated with low platelet count, and he was provisionally diagnosed earlier as treatment refractory ITP. So this is his graph over the past many years. So at the this thing in 2021, he was 23 years of age. His history started in 2003 at the age of 6 years. He had epistaxis and ecchymotic patches, which were noticed by his parents. The bleeding time at that point of time in 2003 was done, which was abnormal. But this thing available workup at that point of time was all inconclusive. In 2008, at the age of 12 years, he had multiple joint pains and polyarthralgia. He was thought to have a juvenile inflammatory arthritis, and he was started on steroids at that point of time. The steroids were continued in varying doses for 2 continuous years. In 2011, at the age of 15 years, he underwent a dental procedure which showed a prolonged bleeding for more than 1 hour, which required intervention in the form of stitching. It was controlled with oral tranexamic acid eventually. At the age of 2014, at the age of 18 years, he was finally diagnosed with XDR pulmonary tuberculosis. He had got multiple splenic abscesses. He was treated at Hinduja Hospital with second-line AKT. But surprisingly, even though he had severe thrombocytopenia in the range of 30 to 40,000 platelet count, he had no bleeding with IM injections of streptomycin, which he used to take weekly. In 2016, he had a mild frontal IC bleed for which he was admitted. So at this point of time, his physician referred him to hematology. A bone marrow was done for this patient, which showed adequate megakaryocytes. An autoimmune workup was negative, but the diagnosis at that point also still remained unclear. A trial of IVIG, romiplastim, L-trombopag was done. Romiplastim had just been launched in India at that point of time, and all of them failed to improve the platelet count. So he was continued on follow-up. In 2018, he developed a complication due to tuberculosis, that is tubercular bronchiectasis. He had a massive episode of hemoptysis, and he required SDP transfusion for management. Splenectomy was advised at that point of time as a treatment for refractory ITP, but it was deferred as he was still on AKT at that point of time. In 2020, he presented to the ER with hematemesis. Again, he required an SDP transfusion. His endoscopy showed gastritis. AKT was completed in February 2020 and then stopped. He was counseled for splenectomy thereafter. So September current admission, he was admitted with another episode of massive hemoptysis. The platelet count was less than 10,000. This time he also, apart from thrombocytopenia, had leukopenia in the CBC. He was diagnosed with iron deficiency anemia. He had significant weight loss over the past 6 months. He was anyways very cachexic, but he had a weight loss of almost 6 kgs in the last 6 months. He was thoroughly evaluated for active tuberculosis, but he was found to be negative. He received 6 SDPs over 10 days, but there was no increment in the platelet count at this point. Therefore, he was diagnosed as platelet refractory. On examination, he also had moderate splenomegaly, 6 to 8 centimeters, which had never been documented earlier. This was a chest X-ray which showed bilateral extensive bronchiectasis. As he had new onset splenomegaly, we decided to repeat a bone marrow biopsy and reconfirm the diagnosis at this point. The bone marrow biopsy was done to our surprise cellular bone marrow with marked dysplasia and grade 2 fibrosis. We were very confused at this point of time whether this is a primary or reactive fibrosis in the marrow, which is secondary to the tuberculosis, or probably due to the anti-tubercular therapy. To distinguish between the two, we sent a conventional karyotype, but it was a normal 46XY normal diploid male karyotype. The FISH panel for MDS related mutations in view of dysplasia was negative. So at this point, with extensive discussions and a review by Sir himself, we decided to go ahead with a clinical exome sequencing. Clinical exome sequencing showed a NBL2 mutation, which was associated with a gray platelet syndrome. As this syndrome is very rare, it was still considered to be a variant of uncertain significance, but in these particular cases, it can be considered to be a very important finding and probably relates to the correct diagnosis. So we made a final diagnosis of gray platelet syndrome with secondary myelofibrosis. So at this till this point of time, we are not even in our wildest dreams thinking about this particular syndrome. So we went back and we read up on it. So basically, gray platelet syndrome, there are less than 200 identified cases worldwide. It is an autosomal disorder, recessive disorder in most cases. It is rarely an autosomal dominant disorder in case of Ashkenazi Jews who have a family history. This is a progressive disorder. It usually begins with thrombocytopenia in childhood and proceeds to myelofibrosis and splenomegaly as the age advances. Definitely has a shortened overall survival. The characteristic findings which are there on the peripheral smear is the presence of this thing platelets which are hypopigmented, and therefore it is called gray platelet syndrome. This is the particular gray platelets that can be identified. So electron microscopy, we did try to find out whether electron microscopy for such patients is available, but it was extraordinarily expensive in Mumbai. So we were not able to do it. So this is how a megakaryocyte with a gray platelet syndrome looks. Basically, the problem is bone marrow megakaryocytes are absolutely normal, but there is a defect in the functional alpha granules in platelets, which results in the characteristic hypopigmented gray platelets. So this is a available image of a gray platelet syndrome, which can see we can see the difference between the normal as well as the gray platelet syndrome megakaryocyte. So management strategy for this patient. We considered a bone marrow transplant, but the problem was that due to probably delay in the diagnosis and due to extensive bronchiectasis, we had to defer that. There was a very high risk of transplant-related mortality in this case. We decided to do close follow-up. We told him to take tranexamic acid to control minor bleeding episodes. We specifically instructed him to reserve SDP transfusion only in case of severe bleeding episodes, as he already showed signs of refractory thrombocytopenia. Family counseling was done. The brother's clinical exome was done. It is an autosomal recessive disorder. Luckily, he was negative for the index mutation. Splenectomy was advised only if the patient had intractable bleeding and we were not able to control the symptoms. Since then, in a year follow-up, he has not bled till now. He is continuing with his daily activities at a college in Bangalore. So with this case, I would like to highlight one of the most impactful recent advances in, I would say, clinical medicine, the next generation sequencing in hematology. So basically, this journey of next generation sequencing has started in 1990 with the Human Genome Project, which was launched in the US. The project was expected to last for 15 to 20 years, and it was a attempt to map the entire 3 billion DNA base pairs in the human genome. Very surprisingly, they finished it in only 13 years as compared to the estimated time of 20 years. So what is even more astonishing is that what took 13 years then takes only 21 days now. So these are few of the interesting cases we have diagnosed using NGS. All of these patients had been extensively evaluated with routine techniques and were for this thing. We did know that they have hemolytic syndromes, but we were not able to come to a final diagnosis till the availability of NGS. So a pyruvate kinase deficiency with a PKLR mutation, hereditary xerocytosis PIZO1 mutation. This was a very interesting case because the patient was almost planned for a splenectomy. And as we know that in case of PIZO1 mutation, splenectomy is contraindicated. So hereditary elliptocytosis with an alpha spectrin mutation. In case of refractory anemia, we identified an old man who had only beta thalassemia trait but was requiring transfusions every 2 weeks. So on doing NGS, we found that he has an alpha gene triplication, and that was the reason why his phenotype required repeated blood transfusions. A myelodysplastic syndrome with SF3B1 gene mutation, that is the RARS, refractory anemia with ring sideroblast. Bleeding disorders, that is the Gray-Platelet syndrome, which we showed right now with the NBL2 mutation, and May-Heglin anomaly with the MYH gene mutation. Malignancies, hematological malignancies nowadays, actually we do NGS, but the most impactful ones according to me are CML with a T315I mutation, especially when they are in the chronic phase, and we know that they are not going to respond to any tyrosine kinase inhibitor except for ponatinib. So these are the patients who should be electively taking up for a bone marrow transplant. Multiple patients with MDS and AML. In fact, AML diagnosis and prognosis is completely dependent nowadays on next generation sequencing. So the take-home message is that advances in hematology are fast-paced, exciting, and meaningful. In chronic hematological disorders, watchful observation is better if the patient is asymptomatic. This holds true for a variety of hematological problems, but the key word here is watchful observation, not loss to follow up. Many hitherto unsolved mysteries are now being unraveled with powerful new diagnostic modalities. We should exploit them to their fullest potential. And NGS is a wonderful example of clinical translation of basic research. Thank you. So I would like to ask the chairperson the question from my side. How do you proceed with patients who you have extensively evaluated and still cannot come to a conclusive diagnosis?
Actually, I am practicing for last 4 decades, and our domain of low platelet count, we usually feel dengue, malaria, leptospira, then some drug induced, and sometimes ITP, and very rarely at the most leukemia or DIC. But this is a very rare type of case, and I'm sure a lot of even audiences might have heard gray platelet syndrome name first time in their life. But the recent advances in the genetic medicine and molecular biology has shortened the diagnostic period. And now with this new technology, new generation sequencing, we are able to diagnose these diseases. So I just wanted to know from you, what is this gray platelet? Means what are the granules in the platelets?
So, sir, there are two types of granules, just to be very technical, alpha granules and dense granules. So, in this particular disorder, there is a deficiency in transportation of pigments and other materials into the dense granules. So, the patient actually has dense granules in the platelets, but the pigments are not transferred into the dense granules. So, they are as good as ineffective.
So it indirectly means that these platelets are dysfunctional platelets.
Yes, sir. This is a platelet function disorder.
So it is a double whammy. The platelet count is 10,000, and then those 10,000 platelets are also
They are also
dysfunctional.
dysfunctional. Yes, sir. So even
So
at
normally,
60,000, they will still bleed, sir.
Normally we are having a little bit confusion that at what level of critical level of platelets we should transfuse the platelets, and we clinician just rely on the clinical picture where there is any evidence of bleeding. But in this case, will you increase your threshold or decrease your threshold?
So what I have learned from Dr. Sanyal is that this thing only to transfuse if the patient is actively bleeding. And in such cases, definitely if the patient is going to undergo elective surgery, we would consider a platelet transfusion before taking him for surgery.
Are we doing this new generation sequencing in our lab here?
New generation sequencing is very much available, sir. It is available. This thing, in fact, I probably Dr. Agarwal sir will be able to confirm. But we are using it left, right, and center in hematology all throughout India.
Yeah, because we are old generation people, so this flow cytometry and then this fish test and immunofixation, all these things we have learned from Dr. Sanyal only. And I'm very thankful because of the Fortis, we people have again started learning further and further.
Thank you so much, sir. Manish, sir.
Yeah. Thank you, Dr. Sanyal and his team for this wonderful feast of academic session. I think NGS is a good modern tool for evaluation. Even in COVID time, all the COVID virus genes, mutations, and variants we came to know because of this NGS technique. So I have two questions actually for hematologists from physician's perspective. I can take liberty to ask Dr. M.B. Agrawal, sir. I remember, sir, when I was in second year MBBS in Sion Hospital, it was my first unit, and I am privileged to see him today as a chairperson. Uh, Sir, we get a lot of patients with thrombocytopenia in our routine OPD or during health checkups. They are labeled, we take hematopinion and they are labeled as mild ITP without any symptoms or without any bleeding. Platelet counts ranging from 80,000 to 1.23 lakhs. So how frequently we should call them for monitoring, or how frequently we should monitor them, and any specific thing to be kept in the mind?
So I suppose you're talking about established ITP.
Yes,
So if it's a chronic ITP, our cutoff is just about 30,000. If the platelet is 30,000 plus, that patient will have no problems at all. You don't need to do even treatment for that patient. So we just follow up to see that the patient is stable or not,
Yes.
leave him alone. Those who got under 30, then they need treatment. If they're needing treatment, then you keep following them at some interval to see their response and any toxicity of the treatment.
Any elderly patient, we should closely monitor them every 3 months or 6 months. Any recommendations are there, sir?
The cutoff will be same, that if they are maintaining their own platelet count above 30,000, you leave them alone. If it is below 30,000, you treat and keep it above 30,000. And in that case, you will follow them up because you want to keep the response is there and there is no toxicity of the treatment.
Yes, sir. Thank you very much.
So my question to Gajra sir, sir, in the pandemic of thrombocytopenia in Mumbai monsoons, how do you distinguish between these cases related to viral fever and other hematological disorders in your practice?
No. Yeah, monsoon is actually a season of fever with cytopenias. Many a times we also get confused, but in a diagnosed case of like parasites are positive or dengue is positive, then it's easy to confirm. But in other cases where these parasites are negative and viral markers are negative, then these cases are really challenging. In such cases, if it is a persistent, then we really need to investigate them in detail. And then we may pick up some autoimmune disease or autoimmune anemia or autoimmune cytopenias in such cases.
Thank you so much, sir. I'd like to invite Dr. Gayatri to now come and take over the stage. Thank you. And thank you for this wonderful opportunity to be a part of this.
Thank you, our presenters and the chairperson, for your networthy presentations and the illuminating discussions. So you guys must be wondering, we have called up the CME and we have not distributed any hard copy material for reading, right? So we have got digitalized. So you must have all noticed there is one QR code kept on the table. So whatever reading material you would wish to read about, you can scan the QR code and you can go through. So we have all the materials uploaded on the QR code. So this was the first half of the session. We are yet to go with the second half. So we can go for the short break and let's come back into 10 minutes back. Thank you so much.